Good evening to all friends and colleagues. I welcome you to this symposium on management of advanced non-small cell lung cancer. So I am, if somebody doesn't know me, I am Dr. Shyam Aggarwal. I am in Delhi at Sir Ganga Hospital as head of the Department of Medical Oncology. So as you know, over the last decade or so, or even more, several critical, crucial and revolutionary changes have happened in the management of advanced lung cancer management. So we'll go through those in the next 40 minutes and then we'll take your questions. So I'm beginning the talk now. I think the centers from Chandigarh, from Indore, Kolkata and Delhi are together. So I welcome you all to this program. So the topics which I'm going to cover will include adenocarcinoma without oncogenic drivers, squamous cell carcinoma, EGFR inhibition, ALK inhibition, immune checkpoint inhibitors, and I think the last part is also very important, which is molecular testing in lung cancer, how it is evolving. So today, if you are faced with a patient with advanced non-small cell lung cancer, you need to differentiate by doing IHCs such as TTF1, P40, and P60, whether you are dealing with a squamous or a non-squamous. And then we need to look at the drivers, whether they are present or not. So the first part of the talk goes for patients who have no oncogenic drivers. And this was the initial Schiller protocol in which 4 drugs combinations were compared. And as you can see, they all gave the same efficacy, whether it was paclitaxel or docetaxel or GEM or vinorelbine combined with platinum. But then the importance of histology was understood by Scagliotti et al. When he compared cisGEM with cis-PEM, and you can see the blue curve giving you a survival benefit in patients with adenocarcinoma of the lung. And that has become the standard of care over the last about 10 years or so. There is a role for bevacizumab, angiogenesis inhibitor, when combined with paclitaxel and carboplatinum. Well, it can give you a better overall survival than as compared to patients who do not receive the BEV. But this being expensive, it is perhaps not used that often. The Paramount trial, which has really changed the practice, is the utility of pemetrexed maintenance after cisplatinum pemetrexed 4 cycles. And again, you can very clearly see a p-value and a hazard ratio favoring the use of pemetrexed maintenance after you have achieved either stable disease or a CR or a PR. So yeah, you can see the curves here. As far as bevacizumab with pemetrexed and platinum is concerned, you did not get statistical significance, but numerically it was better. But because I think due to the cost factor and due to these results, bevacizumab is not combined usually with platinum and pemetrexed. So what about second line in patients who don't have any oncogenic driver? So these are 4 agents, docetaxel, pemetrexed, which was earlier used before the availability in the first line, erlotinib, and I think the last one is perhaps hidden, that is the use of nintedanib and docetaxel. So the last one is currently giving you the best overall survival benefit, 12.6 versus 10.3. So if you have a patient who's failing pemetrexed and has no oncogenic drivers, so you can consider the use of docetaxel and nintedanib. Revel trial used ramucirumab with docetaxel, again an anti-angiogenesis inhibitor, to show the efficacy in patients with non-squamous malignancy. So last in this group is the use of nivolumab, which has shown superior efficacy than docetaxel and better tolerability when you use nivolumab after the failure of first line pemetrexed and platinum. And this compares better than docetaxel in terms of in the toxicity and as well as survival, and has got the approval. The cost is the main hindrance here. So if you look at the bottom line, basically it is showing that over the years, from 6 months survival, we have come almost to 18 months or so in patients who don't have oncogenic drivers. So what about squamous cell carcinoma, and what is the role of EGFR targeted drugs and immunotherapy? So squamous is now less than adenocarcinoma, around 30%, and major airways and central tumors, patients are smokers. So a very small proportion of patients, especially who are non-smokers and who have an adenosquamous component, should be looked for EGFR mutation. And why we're talking of EGFR inhibition is because they have a high incidence and high EGFR expression on the tumor cell surface. So this is again the same trial showing that in squamous, cisgem or carbopacly delivers better than PEM, and therefore these are the standard of care today. So what about EGFR targeting in first line? So this was the trial from Perker et al., where they showed the efficacy of cetuximab in terms of, see the hazard ratio 0.62, but it really didn't stand the test of time. But you did get some, indication that the EGFR inhibition works in squamous cell carcinoma also. And this drug, although not available, necitumumab, which is again an EGFR inhibitor, shows you a 5% improved survival at 1 year and 3% at 2 years, and the hazard ratio is 0.84. So clearly saying that EGFR inhibition cannot be ruled out in patients with squamous cell lung cancer. And this is again the BR21 study, which shows that erlotinib does work, and docetaxel is also effective in patients who are receiving first-line chemotherapy. So that is after the failure of those two. So as I said, the EGFR is overexpressed in patients with squamous cell carcinoma. And not only that, there is data for HER2 as well as HER3, and therefore we are looking at drugs like afatinib. So afatinib, therefore, was compared with erlotinib in a trial after the failure of first-line chemotherapy doublet with platinum. And as you can see here, the LuxLung 8 shows a progression-free survival with a hazard ratio of 0.81 and an overall survival, again, a hazard ratio of 0.881 in favor of afatinib. So as we understand that this is a more potent EGFR and HER2 and HER3 inhibitor. And again, in the squamous, there is numerical data, but not in favor of the anti-angiogenesis drugs. But this is not approved at the moment. It's only approved for non-squamous. So I'll just skip this slide. I'll show you later. Again, like adenocarcinoma, in squamous cell carcinoma, you can see the overall survival benefit with nivolumab without even testing for any PD-L1. You see the 1 year overall survival to the tune of 42%, and for docetaxel it is only 24%. So the drug is approved irrespective of the type in the second line after the first line has failed. Not only nivolumab, even atezolizumab, and I'll tell you more about immune checkpoint inhibitors later on. So now switching gears to EGFR mutant adenocarcinoma and how we should approach in first line. So this is an interesting curve which we have now, that patients who have oncogenic drivers, with the help of targeted therapy, they do much better than as compared to patients who do not have oncogenic drivers, because they don't have access to those drugs in the targeted. So now if you look at the non-small cell lung cancer, this is of course the American or the Caucasian data, where EGFR mutation is seen in 15%, whereas in India and other Southeast Asian countries, the incidence exceeds around 30%. So if you look at the pie chart on the right side, the EGFR mutation is seen in squamous cell carcinoma, as I just mentioned, in around 5%. So this is the exons which show the EGFR mutation. It is mainly confined to exon 19, which is exon 19 deletions, and exon 21, which is L858R mutation. And these two exons, they account for nearly 90 to 95% of mutations in the EGFR. Exon 20, which is T790M, shows mutations primarily to the tune of less than 1%, as you can see here. But this becomes important when you have resistance to these first and second line EGFR inhibitors. There are some cases with exon 18 substitutions also to the tune of 5%. So this is the kind of picture, which you see very slowly emerging: bilateral bronchoalveolar carcinoma, typical of EGFR mutated adenocarcinoma. And these were the trials from Tony Mock, the IPA study, 9.5 months PFS as compared to chemotherapy, and the UOTEC trial showing the erlotinib efficacy as compared to chemo. But however, the overall survival benefit has not been shown whether you use gefitinib or you use erlotinib as compared to chemotherapy in the first line. So this is because of the crossover effect. And then we have the emergence of the third drug, which is the second line, which is an irreversible TKI, afatinib. As you can see, there's inhibition of EGFR, HER2, and HER4. And this was a study where they included patients with EGFR mutations, LUXLung3 and LUXLung6, and then they compared with the chemotherapy. And as you can see, the afatinib arm, which is the blue arm, is showing a better efficacy than as compared to either of the chemotherapy drugs. The P values are highly significant, and hazard ratio is 0.47. Again, the benefit was to some extent more in patients who had DEL19 than as compared to patients who have L858R. I mean, the overall survival touching almost 3 years, which was very impressive. And this was the first time they showed the survival benefit, especially in DEL19 as compared to chemotherapy with afatinib. As I showed you earlier, with erlotinib or gefitinib, there is no survival benefit, but in DEL19 mutation type, you can see some survival as compared to afatinib. So this was a study again to show the superiority of afatinib over gefitinib in EGFR mutants. However, you have numerical, superiority for afatinib, but if you look at the hazard ratio, it is 0.86 and the p-value is 0.25. Even if you look at breakup DEL19 and L858R, you only have numbers superiority. You don't have the statistical significance when afatinib is compared to gefitinib. Well, this is the only drug, afatinib, which has shown efficacy in exon 18 and other mutations in exon 21. So what about using erlotinib with bevacizumab? Well, there is some data to support the use of erlotinib and bevacizumab in EGFR mutants. And as you see, the hazard ratio is very robust, 0.54, 16 months versus 9.7 months is the progression-free survival. So this is the toxicity, which is the same. And as you see here, this was the same patient I showed you when the patient was exposed to EGFR inhibitor. You can see the clearance of the disease in just about 3 months, August to October 2014. So now coming to the important issue, which is the burning issue or topic of today, that is, what are the mechanisms, molecular or otherwise, for patients who develop resistance to either afatinib or to gefitinib or to erlotinib. So T790M stands out to the tune of 60%. And then the issue of biopsy is there to look at the small cell conversion into small cell cancer, so which is very important. So you should aim for a repeat biopsy for looking at small cell conversion. And these are the other mechanisms like MET amplification and a combination of these. So, but T790M, takes away the focus because of the availability of the new drug, which is called osimertinib or Tagrisso. And as you can see, the PFS after failing first line EGFR is to the tune of 11 months. And as you can see, a large number of patients, 66% of the patients when exposed to osimertinib who have T790M, well, they will have a response. So this is the AURA3 study where chemotherapy was compared with osimertinib, and this is a positive trial, reported first time in World Lung Vienna, 2016. So the question is this sequence correct? So should we expose all our patients to gefitinib, erlotinib, or afatinib in first line, and then osimertinib, or we should give them osimertinib from the word go? So so you need to have a PFS of around 24 months to beat the two drug sequentially used. So that is the FLORA study. The report of which study is going to be reported, I believe, in this year ESMO coming in. So these are the conclusions, coming in from the studies which I've just shown you. the other important thing about osimertinib is that this is a drug which crosses the blood-brain barrier and has excellent efficacy in patients who have leptomeningeal disease or brain metastasis, number one. Number two, this is a mutant selective drug as compared to the other first and second generation, and has very few side effects. So it's a fantastic drug to use, and I think current indication is after the failure of first line. So what about now switching gears to ALK rearranged non-small cell lung cancer? So this is again, how we should be looking at the ALK patients. So what are the characteristics of such patients? So again, signet ring morphology, adenocarcinoma histology, never or light smokers like EGFR mutation, or younger than ALK negative NSCLC, and brain metastasis, pericardial and pleural effusion. So, if you have a patient who has non-smoker, brain mets, pericardial effusion, kindly suspect ALK, which is there in about 2 to 5%. And how should you be testing for it? I think in our setup, people are generally resorting to IHC, but I think FISH is also an important test which can be done. And I'll tell you subsequently that the NGS or next generation sequencing can also be done, which is approved now by FDA if you have the technology available. So I think you see all this data of using crizotinib versus pemetrexed in first line without any systemic therapy. And these are excellent, response rates, and 74% versus 45%. And you see the median duration of progression or response, virtually 11.3 months versus 5.3 months, favoring crizotinib. So if any patient who is tested positive for ALK should be subjected to crizotinib as of now, because that's the drug which we have in first line, and you have the PFS advantage, which is very, very clearly seen here. And this is a slide not to go through the details of side effects. One side effect which I want to mention is you must watch the liver function test very closely in the first 1 to 2 months, because there are patients who can get into very high levels of SGOT-PT, which will require a withdrawal of the drug. So you need to be very careful, because we had one patient who did not tolerate the drug. Again, like the EGFR data, the survival with crizotinib versus chemo is the same because of the crossover. And again, this is an important issue because ALK positive patients have brain metastasis, high incidence of brain metastasis. So depending upon the number of sites and the symptomatic or asymptomatic, one has to take a call. I think currently people are all favoring stereotactic radiation, because you're able to deliver a much higher dose to the individual tumor site as compared to whole brain RT. So whole brain RT is virtually gone out of vogue. And if you have a patient even with 2, 3, 4, 5, or even more than 6 or 7 sites of disease in the brain, which are relatively smaller, so I think subject your patient to SRS and keep your whole brain RT in reserve for a later date, because the quality of life can get jeopardized with this. So brain metastasis, if it is absent, it is certainly better than as compared to patients who are, with brain metastasis. And these patients, crizotinib does better than chemotherapy. So this is again an important sort of turning point in the management of ALK positive adenocarcinoma, where the newer drugs like ceritinib, alectinib, brigatinib, or lorlatinib, you can see their CNS activity touching almost 60 to 70%. So this is a very important turning point, which we will see in the next 1 year or so, which may change the landscape for treating patients with ALK positive disease in the first line. So I think I'll skip this. So these are the issues, again, like you see in EGFR. What are the mechanisms of resistance? I'll just skip this and I'll show you the slide. This is the ALK resistance slide to show you that unlike EGFR resistance, here the ALK mutation is seen only in less than 1/3. So T790M was there in around 60%. So ALK mutation is not the main mechanism of resistance. So this is, I think, an important difference. And these are certain genes which you are looking at, for secondary resistance. These are the sites in the fusion protein. So these are some of the drugs like brigatinib and alectinib and lorlatinib, which are effective in various mutants. Like you see in CML, you are switching over to either dasatinib or nilotinib. So again, you have to have a list. Again, the issue of second biopsy to discover these mutations is there. But I don't think we have these tests at the moment. So we are switching, from crizotinib to a second line like ceritinib without doing these tests. So this is the study, which is a very important study at the global level, and the Japanese are doing it. The ALEX trial in chemo-naive patients with ALK positive disease. And this year in 2017, they reported a PFS of 25.7 months with the alectinib as compared to crizotinib. So this is, crizotinib is hardly 10.2 months. So it's a huge difference. And I think in the next few months or a year, we will see the indications of alectinib changing, because currently it is second line. But with the emerging data, you need to keep our eyes open and looking at the net, etc., to keep track of alectinib in first line. So I think this is where we stand for ALK positive disease, that using crizotinib followed by ceritinib and looking at the brain metastasis. But I think alectinib is a game changer. And the other drugs like lorlatinib, which are coming later, are also very, very important. So this is again the very important issue, that is the immune checkpoint inhibitors in non-small cell lung cancer. I'll just tell you a little bit brief about basics, which you I think all know. So as we know that cancers are caused by multiple mutations, and these have to be non-synonymous mutations, which result in the occurrence of neoantigens on the tumor cell surface. And these neoantigens, they stimulate the immune cells to kill them. But however, the PD-L1 and PD-1 mechanism is responsible for the proliferation of both the immune cells as well as the tumor cells. And ultimately, if you break this nexus of PD-L1 and PD-1 by these drugs which we have now, we will be getting the immune cells going after the tumor cells, and you can get a remission. So now, what is the data? I've already shown you some of these studies for second line. I think this study is there for nivolumab and versus docetaxel, and the drug is approved in second line in squamous. This is the squamous data. I think all these studies I had shown you before. Now, again, this is the same data for second line in the non-squamous. So this is again the data on pembrolizumab. The difference is that the drug is approved for patients with more than 1% PD-L1 positivity. So as you can see, the PD-L1 positive patients doing better. Whether you use, so the current dose is 2 milligram per kilogram for pembrolizumab, and docetaxel is coming a poor third here. So again, atezolizumab is approved now in second line, like patients, for nivolumab and pembrolizumab. So again, these three drugs are basically looking at the PD-1, PD-L1 mechanism inhibition, and you have these drugs which are defeating docetaxel. I'll just show you one case whom we treated, a few months ago. You can see a lot of disease here in the mediastinum and in the lung. And this patient was then has some abdominal nodes, and patient was stage 4. A patient was given chemotherapy, and you see a lot of progression here just within 2 months. This is a pericardial effusion, as you can see, which was not there before, and went into tamponade. And then the lesion in the lung was not regressing. And then we came in with nivolumab. And after 3 doses, you virtually see a disappearance of the disease in the mediastinum and in the lung. So this was an amazing result with just 3 doses. Although these IO drugs, they're supposed to work slowly, but in this patient, they work very rapidly. And I think we're going to report this patient. The incidence of complete remission is 1 to 3% with drugs like nivolumab. So this patient had a complete remission lasting for more than 6 to 7 months. So this is the comparison. You can see the nodule here, and the nodule is not seen, and the mediastinal disease is gone from the new scans. So what about the drug in the first line? So I think the important biomarker is PD-L1. There's a lot of confusion there, but I think that's the marker we have at the moment, especially for pembrolizumab. And the drug pembrolizumab was compared with platinum doublet in patients who have PD-L1 more than 50% on the tumor cell surface. And this was again, a trial comparing the two, and you see the progression-free survival benefit, and you see the overall survival benefit for patients who have more than 50% PD-L1 positivity, and the drug was approved by FDA in first line for such a group of patients. What about side effects? I think you've heard a lot from various speakers from abroad. The drug is fairly well tolerated, basically immune-mediated reactions, and you need to be careful in the first 2 to 3 months. And as time passes, the side effects, they go down. What about the data for combination with chemotherapy? So it is basically pembrolizumab combined with chemotherapy for adenocarcinoma or non-squamous in first line, irrespective of the PD-L1 status. And this is the response rate. We can see a much better response rate. You can see the progression-free survival favoring the combination arm. However, the survival benefit was not there. But irrespective of this, the FDA did give the approval for combination in adenocarcinoma without testing for PD-L1. However, in patients who have higher PD-L1, positivity, you see the overall response rate to the tune of 80%. So, which was nowhere, near the chemotherapy arm. So, PD-L1 positivity is definitely a biomarker, but you cannot rule out patients just on the basis of PD-L1 because about 10% patients will respond to such an agent. So biomarkers, and this is the problem why the heterogeneity is there, because you're picking up a sample from one area which may not have PD-L1 expression, but the other area may show PD-L1 expression, and there could be a sampling error. So this is another biomarker, which is the mutational burden in cancer, and the non-small cell lung cancer, stands here along with urinary bladder cancer and certain others, because as I said about the mechanism of action, more of the number of mutations, more is the neoantigen presentation to the APCs and to the immune cells, and therefore the role of immune system is there. And that is why squamous cell, which is related to smoking, they respond better. So this is the data showing that patients who have a high non-synonymous mutation burden, their survivals are much better than as compared to patients who have low synonymous burden. And this is the last thing on the immune oncology front, that patients whose tumors, irrespective of the type of cancer, if they have MMR deficiency, mismatch repair deficiency, which results again in the high incidence of non-synonymous mutations because their repair mechanisms are gone and they will have more mutations, and they respond better than as compared to patients who do not have the MMR deficiency. So how to build up on those? A lot of combination trials are there. I'm not going to go into those because CTL1 and other immune modulatory drugs are being combined, and however side effects remain an issue. So the issue is duration of therapy. We don't know how long to keep giving this. We had a speaker who said 2 years is the cutoff, but we are not sure. Combination with radiation, use in curative settings. There are a lot of questions relating to IO drugs which we need to address. So now this is an important part, which is the last part of my talk, the mutations, that molecular methods of testing. So we've been using sequencing like Sanger sequencing, but the issue is that it is very less sensitive. So what we are using is the ARMS technique, which is the allele specific or exon screening. So which is standard at this point in time. For fusions like ALK fusions or for ROS, we normally use FISH. What is happening now is the use of multiplex PCR. So this is the latest in the game, and of course for PD-L1 we are testing. So can we do all these tests with one test, as tissue is very crucial? And this is what FDA did very recently in May 2017, gave the approval to OncoMine diagnostic target, which is an NGS based test looking for 23 non-small cell lung cancer genes, which include BRAF, ROS1, EGFR, and ALK as well. So this is a test which we need to be looking at in our country as well, which perhaps we don't have as technology. I think these are all kits, and as the technology advances, people will acquire this. So NGS is the buzzword, and it is going to stay on and on for all these mutations to be understood. So the other buzzword is ctDNA. So how do you look for T790M in patients who are EGFR mutants? So they have the concordance of plasma ctDNA for T790M as compared to biopsies. So I'll just show you the next slide. So this is an important slide showing you that there is a 51 to almost 70% agreement between tissue and plasma. But if you look at exon 19 and L858R, there is even more agreement, more than 80%, 70%. So you can actually do ctDNA for EGFR mutation testing upfront for exon 19 and 858R. So, but then these tests at the moment, people are evolving in India at this point in time. And if your test is, and they are using techniques like ddPCR, or as I said, you have a multiplex and NGS for using these tests. So if you have a T790M in the blood by ctDNA, well, you will get a similar response than as compared to tissue. But if you have a patient who's progressing on EGFR inhibitor first or second line, and your ctDNA is negative, you must do a biopsy. So if your T790M is negative in the blood, well, then you should do a biopsy before you say no to osimertinib, because that's the ultimate test. But you can rely on the blood ctDNA for giving osimertinib if it is positive. So a repeat biopsy in NSCLC is possible in about 60 to 70% of the cases. This is a data from a large series. So this is another important concept of MRD by ctDNA. This is just a study showing in localized non-small cell lung cancer who have finished treatment with, say, radiation and surgery or chemotherapy. And they do the MRD testing, and you see if there is no presence of any mutation detected on the ctDNA, they don't relapse. If the ctDNA is detected for MRD, you see majority of the patients are relapsing. So this is technology which is preceding the MRI or a PET CT scan appearance of a disease. So just by doing a simple blood test, you can pick up the mutant and predict the relapse rate. So this is a very important thing in science, which is happening in a variety of cancers, whether it is breast cancer, colon cancer, stomach cancer. These are the 3 or 4 areas where the literature is showing the MRD detection by ctDNA analysis. So where are we now in 2016 and 17? We have EGFR and ALK, ROS and PDL1. Well, these are almost there. We must do it, and we are doing it in most of our patients. PDL1 is perhaps not very common because nivolumab does not mandate that. But then as now pembro is becoming available, I think we will be more than keen to do the PDL1 testing. So all these other genes, for example, BRAF, we have the drug, is very expensive at the moment, not available, and therefore perhaps not doing it. MET mutation responds extremely well to crizotinib, and is worth doing it because we have the drug. And in a patient, especially with carcinosarcoma, 20% of the patients are MET mutation positive. So if you have a lung carcinosarcoma, please do MET mutation because you have a high chance of picking it up. So similarly, HER2 mutations, one can detect and put them on drugs like Herceptin. So this is a new potential scenario for first-line NSCLC in the next few years. EGFR mutant, you may go for osimertinib. You know, as I showed you, the FLORA trial may be unfolding in the next 2 months. ALK positivity, as I said, alectinib, ceritinib, and you may forget crizotinib. You know, this is a futuristic view. ROS1 and MET amplification, crizotinib. PDL1 testing, we have checkpoint inhibitors either alone or in combination with chemotherapy. So pan-negative, non-squamous, we are still in pemetrexed and platinum and maybe bevacizumab-related chemotherapy. For pan-negative squamous, we are mainly with a platinum-based doublet and necitumumab. So what about the IO drugs? So they're really replacing chemotherapy in the second line. And this is an important concept, that we are now getting operational cures of patients who are surviving beyond 2, 3, 4 years, 20 to 30%. So this is a scenario which is evolving extremely rapidly. And I think when we started doing chemotherapy for all cancers, including lung cancers, we just had 5FU and maybe platinum, and the survival was hardly 6 months or 8 months. But now we are touching, as you see, 20 months to 40 months or 50 months, and operational cures in some patients who respond very well to the IO drugs. So I think the future seems very bright for NSCLC, for science, but one really has to put in a lot of effort to identify these mutations and choose the appropriate agent for such a patient. So I think with this I can close the presentation, and you can have question answers, and I'll be very happy to participate in the discussion. So thank you very much for your attention from Delhi, from Chandigarh, from Kolkata and Indore. So thank you all, and I look forward to your interactive session. So role of this, I think there are questions which are coming in from Delhi and from Mumbai mainly. Role of nivolumab in first line is not there because the drug was again used without any PD-L1 testing, and therefore it was a negative trial, and it is not to be used in first line at all. The only thing, I mean, you have pembrolizumab available, so if you have a patient PD-L1 more than 50% positive, well, then you can certainly use pembrolizumab in first line for PD-L1 expressing non-small cell lung cancer. So the other question is, should one consider EGFR T790M mutation by liquid biopsy at baseline in patients who have diagnosed with stage 4 lung cancer and adenocarcinoma EGFR wild type? This is Dr. Vashishta Manyar from Mumbai. So as I showed you, the incidence of T790M mutation positivity in frontline is around 1%. So, I mean, you really need to document. So your question is, should we consider EGFR mutation by liquid biopsy? So actually, because the incidence is less than 1%, I mean, it is for you to decide whether you really want to pursue that 1% line, because the chances of T790M positivity is very, very small. So if that answers your question. Okay, so another question has come, that is the role of adjuvant TKI inhibitors after surgery in early stage lung cancer, who are, I'm sure, I think the doctor means that it is the tumor is positive for EGFR mutation. There is actually very negative data by and large, so far in use of gefitinib or erlotinib in patients. This year at ASCO, there was one paper which was showing some positive results, but there were a lot of dropouts, and the paper was reviewed by Dr. Chandra Bilani, and it really has not become as a positive study until now. So it is, I don't understand why these patients are not doing well. I think the only explanation is that the tumor burden is so tiny that the EGFR inhibitor doesn't work in these patients, although the response rates, as you know, in metastatic disease remain very high to the tune of 70%. But I don't know why it doesn't translate in terms of benefit in the adjuvant setting for EGFR mutant adenocarcinoma of the lung. So I think they did attempt, this year also in the ASCO 17, and the conclusion drawn was that this is not all the data was a little positive, but a lot of dropouts and certain other deficiencies in the data collection, which is not making it a very positive study. So the question is bevacizumab already approved as first line in metastatic EGFR negative adenocarcinoma? So I think as per the data available and FDA, etc., Pecli Carbo, the ECOG 4599 study with bevacizumab can be used in front line for patients who have no mutation for patients with adenocarcinoma. I showed you data for PEM, Carbo, and bevacizumab, but then it did not translate in terms of statistically significant result. But Pecli Carbo and bevacizumab can be used if you. But I think the current protocol, which most people favor, is the platinum and pemetrexed. So what do we do when these drugs stop working and do not work in the first place? What is the next step within the field of immunotherapy for patients that do not benefit or stop benefiting from these drugs? So that's an interesting question as to what do you do? So we actually don't know. Nobody knows what is the mechanism of resistance to these drugs if the drug worked initially. So nobody, I think they are collecting a lot of data on biopsies and blood samples of these patients as to why these drugs stop working, what happened to the tumor, what happened to the microenvironment, etc., etc. And we don't have an answer. So, but maybe, if you are using an IO drug, after the first line failure of a protocol, well, then certainly you can go for chemotherapy agents which are available. Say, for example, if you had initially used carbopem, followed by an immuno-oncology drug like nivolumab or pembrolizumab. After the failure, you can go back to docetaxel and nintedanib. So, which is becoming an important combination for the early relapsing patients. So I think we have no choice but to go to the second line or third line chemotherapy, which we have in plenty. So after docetaxel, we have gemcitabine. Then you have vinorelbine. So, we are forgetting those drugs now in the second and third and the fourth line. But we have patients in our practice where we started giving them with carbopem, and then we gave them nivo, and when they failed, we went on to give them drugs like docetaxel and gemcitabine. And I have patients who are surviving beyond immuno-oncology drugs for 6 months or 1 year and so on. Oh yes, the next question is, after using paclitaxel, can we use docetaxel? Well, yes, that is the standard of care for pacli carbo failure, especially for patients in squamous cell carcinoma. And as I said just now, docetaxel, especially in adenocarcinoma, can be combined with nintedanib to enhance the efficacy of docetaxel. So it gives you a superior result than as compared to docetaxel alone. The next question is, patient progressed on gefitinib, done liquid biopsy, on which EGFR is negative and T790M is negative. So can we become EGFR negative post gefitinib? What is the discordance rates between tissue EGFR and ctDNA EGFR, and what is your interpretation? So as I showed you the chart, the algorithm as to how you should be going for a patient who develops resistance to, say, gefitinib, as you say. So you should go for liquid biopsy. This is what you did, and that turns out to be negative. So the false negative rate is around 30%. So which means that you should go for a tissue biopsy and send that testing for qPCR for looking at T790M, and 30 of these patients will be positive. So if you get a positive result, well, then you can start the treatment with osimertinib. But if it is negative, you need to do the tissue T790M, because you will pick up 30 more patients, and therefore they become eligible for use of osimertinib, which is a fantastic drug because it is mutant selective, as I said. Unlike gefitinib, erlotinib, and afatinib, those are only EGFR exon selective. That is why you get the toxicity. So osimertinib does not have any GI toxicity or skin toxicity, etc., because it selects only the mutations in the EGFR, including L858R and deletion 19, etc., etc. So that is the advantage of this osimertinib, and the toxicity profile is so favorable. I didn't show you that, but it is amazing to see such a fantastic toxicity profile. Duration of treatment of TKI inhibitors in metastatic NET is the next question in NSCLC. Can it be given continuously for many years? Oh yes, why not? I mean, you're using imatinib and dasatinib and nilotinib, which is again TKIs. So if the patient is tolerating, go ahead, give it. Keep on giving it, because you cannot say that the patient is cured, because your PET CT scans and MRIs and etc. will not pick up microscopic disease. So if the patient is tolerating, you can go on and on and on for many years if the patient is not progressive or patient does not have any toxicity from the TKIs. Considering tumor heterogeneity in mind, this is the next question. There is some data of combining EGFR inhibitors and chemo in EGFR mutated patients. What are your thoughts? So this is an interesting burning question. Ever since the EGFR inhibitors came into being, there are a lot of preclinical studies in the test tubes and the mice model showing you the efficacy of the combination of chemo and EGFR inhibitors. But unfortunately, there's a recent trial, I think in 2016-17 in the JCO, where carbopem was combined with EGFR inhibitors, showing you numerical advantage, but not statistically significant. And then the other issue which has always been raised is, how to sequence them in a 3-week protocol, whether there should be a 10-day gap, or they should be given simultaneously, or they should be interrupted. So we don't have a clear answer. You also know the trial in the second line after the patient has relapsed on EGFR inhibitor. So people say you should continue the EGFR inhibition and continue or add maybe docetaxel. But I think the IMPRESS trial, which was published recently from Tony Mock et al., does not show that advantage. But I think in practice, sometimes I do that. That is combining EGFR inhibitor drug with the chemotherapy, especially in the relapse setting and not in the upfront setting. So I think these are my thoughts on combining EGFR inhibitor and the chemo drugs. So these are still evolving at this point in time, and I think the trials are available with mainly gefitinib and maybe erlotinib. But then afatinib is a little different drug. It is irreversible TKI. It has more, action perhaps in deletion 19. So maybe the data can emerge for combination of afatinib with chemo, favoring the combination arm. But I think at the moment we need to stay away from combination. Only in select patients we can try, case to case basis. So these are very interesting questions. Some of them we don't have a clear answer to, but then I think they really are unfolding at this point in time, because these newer drugs are really, and not only the newer drugs, the liquid biopsy, the NGS, so they're really changing the scenario as to how we should be looking at a patient with lung cancer. We started with histology, like squamous versus adeno, but now we are looking at oncogenic drivers. And as more and more drugs are evolving, and as the technology is becoming much more easier to pick up these mutations, so we are becoming more personalized, as we say, for treating patients with lung cancer. And of course, the immune oncology is the buzzword these days. Where? Yeah. Oh, okay. Sorry, there are a lot of questions. So can the studies on extrapolation used for treatment of head and neck cancer, non-squamous cell with EGFR mutations? I don't get this question. I think they say, so actually you have to understand the difference between the mechanism of action of EGFR inhibition in squamous cell versus adenocarcinoma. So in adenocarcinoma, we are targeting the EGFR mutations, whereas in squamous cell carcinoma, these mutations are not there, but there is a lot of overexpression. This is what I showed you from the FLEX study, where they use cetuximab, the Perker study. And now you are seeing the superiority of afatinib over gefitinib in second line, or erlotinib for that matter, in squamous cell carcinoma of the lung. It is approved. So it is not inhibiting because there are no mutations in the squamous cell. So it is the overall expression. And yes, in the head and neck cancer, again, it is overall expression of the EGFR, and that is why the Erbitux and the Biocon drug works. So it is the EGFR overexpression, definitely. The next question is gemcitabine beneficial, as its initial response is very good, but complications are troublesome? I thought gemcitabine is a much better and well-tolerated agent. One can always look at the dose modification depending upon, the only issue is the patient has to come day 1 and day 8. But I thought, my experience is that gemcitabine is definitely helpful and a drug which is very well tolerated. And perhaps, in women, there is no hair loss, if that is an advantage. So what is your regimen of choice in adenocarcinoma, NSCLC, cisplatinum, paclitaxel plus Avastin versus cisplatinum pemetrexed? Well, certainly, I think I made that statement that I think most of us are using PEM with the platinum, which could either be cis or carbo, and Bev is virtually out as far as our country is concerned, for reasons of cost. and cis and PEM or carbo or PEM give you the same efficacy. So that is become the default drug combination for patients who have adeno-CA without driver mutations. The next question is, in EGFR mutated patients, progression on EGFR inhibitors without any targetable mutation, we start chemo, and should we have to continue EGFR inhibitors also? Your thoughts? So I think I addressed this question already, that the IMPRESS trial says that the addition of docetaxel or chemotherapy to erlotinib is not helpful. But I think there are phase 2 studies showing that if you discontinue the drug, the patients, that is the EGFR inhibitor drug, the patients can bounce back. I haven't shown you data of that effect, but if you look at the randomized data, the IMPRESS study, they are not for combining the two. So the next question is, what are the options after disease progression of squamous cell lung cancer on second line nivolumab besides docetaxel? So as I think we just discussed, so you have all those chemo options open to you, such as gemcitabine based combination or vinorelabine combination, because once they don't have any, so if you have somebody who can do some gene testing, I mean, you can always go for that and look for some clinical studies or trials. But then I think chemo at the moment remains the mainstay of treatment. So unless you document some mutation which has a drug for it. So I think a lot of patients and physicians are looking at NGS data for 40 genes or 80 genes or even 250 genes, because the cost goes up as you increase the number of genes. And I think some of those well-to-do patients are demanding, and even the physicians are looking at 40 genes or 80 genes. But I don't think there is any guideline at this time, because I mean, it is only going to be entering into clinical trials. But I think if somebody is very keen, so don't refuse them, and you may get some positive lead, particularly in adenocarcinoma, such as MET amplification or MET mutation, as I said, which could be amenable to a drug like crizotinib. So which could really change. And don't forget ROS1. So you should always do that. We have a patient with ROS1 positive disease with brain metastasis, was virtually on deathbed, and she's going on and on and on for a year, more than a year, with excellent health now. So I think although the incidence is very small, so I think you need to keep all those issues in mind, especially if somebody has the resources. And I think the Foundation One provides you one of the best labs to give you the NGS results in about a month's time, but it is very expensive, more than 2 lakhs for one test. So it is more comprehensive. It even gives you the tumor mutation burden, which they also, I think, give you the PDL. It's a very comprehensive test, but then it is expensive at this time. So are there any more questions? Or I think 2 minutes. Yeah, sure. We are here to take any question from you. It has been a very interactive session. There are a lot of issues which we have discussed relating to the adjuvant treatment, relating to the EGFR overexpression, certainly the IO drugs, use of bevacizumab, and I think it's very positive now, because we can expect patients to live at least 2 years, even if they don't have any driver mutation, provided you can the drugs, use them sequential fashion. So the question is, what adverse effects have you faced with nivolumab? Actually, I've used nivolumab in over 50 patients so far in various indications, and we've seen hypothyroidism after 3 months. We've seen some skin toxicity like itching, but actually no major toxicity, which people are fearful about. For example, colitis, pneumonitis, or hypophysitis. So these are some of the deadly or dreadful complications of nivolumab. So far, we have been extremely lucky that we have not seen. People have seen, hepatitis, which is a very difficult complication of nivolumab, requiring drugs like infliximab, etc. But most of these patients require a high dose or a full dose of steroids, especially if they have grade 2 or 3 toxicity. And because the issue is that nivolumab should not be given for patients who are on full doses of steroids or prednisolone. So you need to, if you have a complication with nivolumab, so you start them on prednisolone and taper it off in next 1 month or so, and bring it down to 5 to 10 or max 15 milligrams, and then you can use nivolumab. But if your requirement of prednisolone is higher, because the action of nivolumab and prednisolone is contradictory. So on the one hand, we are trying to stimulate the immune system, and the steroids are suppressing. So patients should be on a low dose of steroids, less than 10 milligram preferably, for them to be on nivolumab. And that is the reason, why patients with SLE and rheumatoid arthritis, etc., who are uncontrolled on big dose of steroids should not be given these drugs. And anyway, there is a chance of their basic disease of autoimmune disorder getting aggravated. So can this, next question is, can this EGFR targeted drug be used in lung cancer prevention in those with mutations positive on genetic screening? I don't think whom are we going to screen. There's any screening program for women who are non-smokers, who are in the middle age. So that is the group who get this mutation positive. So this is a very interesting thought. That's what I can say. So when we don't have any data for even patients who have got the cancer, has been removed by surgery, and the adjuvant TKI doesn't work. So I don't think you need to do a trial and generate such group of patients where you can do this. So this is a question on cancer prevention, which seems very far-fetched at this point in time. So what PDL1 inhibitor you choose, Nivo or Pembro in second line? So you can choose either of them, because Nivo does not require any PDL1 testing. But if you are very keen for Pembro, then you have to document the presence of PDL1, because all these drugs, I was asked a question, so after nivolumab, can you use Pembro? Can you go on to the third drug like atezolizumab, etc., etc.? So all these drugs, they are working on the mechanism of action of PDL1, PD1 pathway. So whether you use N or P or atezo, they have the same action, and therefore, if one drug fails, the second drug is not going to work. So you have to change the line of treatment. That is, as I said, in the third line, you can go on to for chemotherapy. So this question which was asked earlier, that patients who was very interesting. The patient who's on EGFR inhibitor progresses on this EGFR inhibitor, and you look for T790M. So the question was, can the patient become EGFR negative post gefitinib? I don't know if there are any studies to that effect, but they may be actually negative, or maybe harboring a clone which is suppressed by the gefitinib or erlotinib. And but that was the thought for combining chemo and the second first generation TKI, but then it hasn't really stood the test of time. I think that is where we are. Okay, Dr. Anup Majumdar is asking from Hyderabad, how many times circulating DNA is to be performed? So this brings to a very important question. That is the validation tests. That is the reliability of the lab, which is doing the circulating tumor DNA. So the method which is currently adopted by most of the labs in India is the use of digital droplet PCR. So which is a fairly reliable test. and this is what was utilized, or the beaming technique, which was utilized in the international studies. So they give you the same sensitivity and specificity. So you need to perform the test once, and the reliability of the test is confirmed by and large, because when you're doing the ctDNA for T790M, you're also looking at the other mutations like L858 or deletion 19. So if in the same sample you see the presence of the old mutation at a lower level and there is no circulating tumor DNA T790M, so that means that the assay which was done, or the test which was done, was correct. But if your test is negative, as I said, you need to go in for tissue biopsy to look at those 30% of the cases who may be negative in the blood but are positive in the tissue. Okay, for maintenance therapy, which is the better option, or gefitinib or erlotinib? I don't think there is any head-to-head trial, but in a patient who is EGFR mutant, I think these days erlotinib is perhaps the preferred drug in the setting of maintenance therapy, because you have the trial data in favor of erlotinib. And I think most of the physicians, by and large, have moved on from gefitinib to erlotinib. But then I think you will get the data is there with certainly with erlotinib in EGFR mutants, and therefore I'll prefer using erlotinib if you ask my view. So I think very interactive session, and I think I'm extremely grateful to NATCO, who brought us together in this forum or in this symposium on lung cancer. Certainly, I have a few thoughts which I've gained from your questioning, and certainly I hope there were certain thoughts which I was able to convey to you, which would help you, take home some messages as to how to treat patients with advanced non-small cell lung cancer with or without driver mutations. So with this, I thank you all. Thanks to NATCO again once more, and good night to everybody. Thank you very much.